The analogy some people use is HIV disease. It works to some extent. It doesn't work in others, but if you keep in mind, I saw my first case of HIV in 1983. I remember driving to the airport at midnight to pick up the pentamidine the CDC was shipping out for my pneumocystis patient, thinking, I'll never see another case of this. And that certainly was not true. But it wasn't for 12 years until 1995 that we had adequate antiretroviral therapy to treat HIV. So look at this disease we're currently involved in, where within 9 months of the disease hitting the United States, 10 months, we had vaccines available. Less than 2 years, 18 months, we had antiviral therapy available. I will not say that science cured this problem. I will say science mitigated this issue. But I think that when you look at HIV disease setting the stage pharmacologically for management of hepatitis C, hepatitis B, and COVID, it's really impressive watching that movement forward in such a way that it benefits people. And that's the only silver lining you'll find in this whole discussion, probably, in the sense of this disease state. I'm going to cover a few things. Pathophysiology of disease, you have to understand that, particularly the cell cycle, to look at the therapeutic interventions we're going to cover. I'm going to focus on a number of different sites. Acute interventions for sure, no matter where you are in this arena, ambulatory, inpatient, long-term care, you really have to know what happened in the acute arena to know what to do for your patients when you're seeing them in follow-up post-discharge. We'll talk briefly about post-COVID discharges, things to keep in mind. So it's critical that when you receive your patients in the acute arena, that you have some sense of how they were treated, what interventions they went through, so you can predict or at least think about concerns moving forward. Vaccine development is obviously part of this discussion, which I think is fascinating. And then we'll talk about antivirals. And during that discussion, really be focused on the oral antivirals that allow us to preclude hospitalization, which is, I wouldn't say a game changer, but is quite impressive. I'm a believer in the animal model of transmission to humans. SARS-CoV-1, 20 years ago, 15 years ago, certainly came down from bats to animals. We'll talk about which animals did this. MERS, the MERS virus, the Middle Eastern respiratory syndrome, came down through camels from bats in the Middle East. And SARS-CoV-2 came from bats probably not through the pangolin, which was the first animal that was felt to be responsible. The pangolin is the #1 trafficked animal in the world. There's a portion of meat which is used for medicinal purposes, and the skin is used for purses and things of that nature. But it probably is not the pangolin. It probably is the Chinese raccoon dog, which recent epidemiologic studies have identified the fact that in the Wuhan market, a high incidence of acquisition of disease occurred right around the Chinese raccoon dog cages. It's somewhat horrific how these animals are used, and I hesitate to even bring it up. They're skinned, typically alive, for their pelts, and that's just perhaps a cultural thing, or just I'm not sure what it is, but that's you can imagine the secretions being exchanged during that event. 85-year-old male presents. This is April of 2020. Extended care facility resident for 3 years. He's not himself. Fever 38, respiratory 20, sat 82%, white count 1800, platelets 98. It's pretty obvious I made this case up, but this is probably half of the 2,000 cases we had over 2 years, and certainly the majority of those coming in the first 3 months in the first, quote, wave. Leukopenia is classic, low-grade fever, hypoxia, chest x-ray, patchy infiltrates, required 4 liters of oxygen. What do you do for this individual? This is his CAT scan. You've seen plenty of these CAT scans. The patchy ground glass infiltrates peripherally. The arrows are certainly added in for effect. And I don't know what you do for this person. Imagine it's 2 years ago, and we all know that it was January the first case in the United States. March 8th to 10th was when most states moved to emergency proceedings. And our first case arrived March 17th. We were very fortunate in Delaware in some ways because we watched it arrive on the West Coast, we watched it arrive in New York City, and this is a disease of high population density, and so it's really a urban population disease. And of course, everyone knows Delaware is merely a rural farm. There's nothing down there but farmland and Joe Biden. So when you don't know what to do, you encourage your group to form a team. And I'm surrounded on this meeting today by PharmDs and PhDs. And the first person you call is your infectious disease pharmacist. And this individual, right in here, Nicole Harrington, Megan Farage, who are our ID pharmacy team, quickly formed a committee of sorts that was well organized with multiple specialties, pulmonary, ID, and hospice medicine, and pharmacy with a core group. We needed research for the convalescent plasma work and some clinical trials work, and of course palliative care is involved. But this group formed rather promptly and met weekly during the first 3 months of this pandemic. And what do we talk about? We talked about what can we do for these individuals. It was absolutely frightening because we had no experience with this virus. There was data on this virus, and if you look at literature as the virus came out, this is all known. This virus had been studied. Coronaviruses are known to do. This is CoV-2, but CoV-1 was studied. And if you look at the way this virus works in you and me, not us right now, number one, it binds to the ACE receptor. Number two, it then becomes absorbed, endositized on the outside, but it comes in and opens up, releasing its RNA. In this setting, the RNA that gets transcribed into peptides, but also gets turned into new RNA synthesis, goes into the new cell, gets assembled, and then leaves the cell. This was already known in April of 2020. We were hoping to find agents that were effective. We do know that hydroxychloroquine had some in vitro activity, and this was the big hope during that time frame. And we took an opportunity to review with our colleagues in other institutions who had been hit by the virus, looking at protocols in other sites, and felt that the profile of hydroxychloroquine was a, quote, won't hurt, might help category with very limited data. I think you're aware of that. But the profile of hydroxychloroquine was reasonable in terms of the ability to achieve adequate levels would not be toxic, unlike ivermectin, for example, which has activity, but the ability to achieve successful levels is of toxicity range. So our initial protocols used hydroxychloroquine. Now, of course, we're using remdesivir, and this works in the ribosomal site where it inhibits RNA-dependent RNA polymerase, inhibiting production of future RNA. We knew that was possible, but it was not available, and this was a production issue as much as anything. Now, of course, you may know, we have other agents, and to make sure that we hone in on what you have available now, Paxlovid works as a protease inhibitor, which inhibits the protein structure reassembly in the site. Molnupiravir, an oral agent also, that works as a cyclidine analog and inhibits RNA production by mimicking building blocks of RNA and making nonsense RNA. So we have agents that work in multiple areas here, as well as monoclonals. But in 2020, in April, we had very little. So for us, we used anecdotal data, protocols from other institutions, and phone calls to colleagues. Our pulmonary team was very linked to some of their prior training sites, and they really did a wonderful job identifying potential interventions, particularly in those that became quite ill. That includes use of IL-6 blockade and steroids. So our initial protocol for all of our patients admitted was hydroxychloroquine, zithromycin for anti-inflammatory effect. Convalescent plasma was a huge intervention that had very little impact on this disease. And in retrospect, it probably is the fact that we gave it way too late. Convalescent plasma is essentially a poor man's monoclonal antibody. And the earlier you give this, the better. That was demonstrated by the Mayo data we participated in, but it was of limited benefits. I think I gave up to 300 units of convalescent plasma in the month of April and May in 2020. I've given it once in the last 2 months. And then we used steroids using the ARDS model, as respiratory failure was the final sort of filter of this disease, moving to the ICU on high-flow nasal cannula, then intubation. We used very little ECMO by decision. That was our choice not to use ECMO. And the hope was to avoid intubation. Once intubated, the risk of future secondary infections was felt to be high, and we tried to minimize that.